Hello, good morning or good afternoon, depending on when you're listening to this presentation. My name is Robin Rome. I'm a nurse practitioner and I work at the VA in New Orleans on the palliative care team. And I'm very happy to be asked to be a part of your education regarding palliative care. Before I get into today's presentation on managing expectations and the art of communicating bad news, I'm going to share a little bit of my story with you and why it is I decided to do the work we do in palliative care. 21 years ago, when I was first called to be a hospice nurse, I never really heard the word hospice before. And from the very first visit I made, I was hooked. I knew immediately it was where I was meant to be. And after a couple of years of making home visits to terminally ill patients, a couple of things really started to bother me. One was that patients were referred so late to hospice they were dying within days and sometimes hours of their admission. Two, it did not make any sense to me that patients and their families had to wait until this point in the disease process to receive the supportive services that were offered by hospice care. And it became my mission to figure out a way to be able to get the supportive services that hospice offered to patients and their families before the terminal phase of their illness. Of course, I wasn't the only one who was recognizing this need, and hence the development of the specialty of palliative care. I decided to return back to school and pursue my nurse practitioner degree, and soon after graduation, I began working in palliative care. As I've continued my career in palliative care, having now met with over a couple thousand patients and families, I've learned that for the most part, people who are facing a serious illness that will eventually reach a terminal phase want two things. They want to live not only as well as they can, but also as long as they can. It's so exciting to be practicing at a time with all of the new advances and all the different disease processes that we help patients through that are allowing even those who are being treated with a palliative focus to meet both of the goals stated previously. However, even with the advances, there continues to be a need to have difficult conversations around end-of-life care and finding out what is most important to people in the face of their serious illness before they reach the terminal phase. If you don't remember anything else from today, please remember this. Don't wait until the patient is actively dying in the critical care unit or is meeting hospice criteria to introduce planning for end-of-life care. It is essential to incorporate palliative care at the beginning of any serious diagnosis. I have no disclosures. So our objectives for this presentation is we're going to define palliative medicine just briefly. I know you've heard about this in another lecture. I'm going to identify patients for whom goals of care conversations are appropriate, list the steps to prepare for a goals of care conversation, and identify the elements of a good goals of care conversation. So, what is palliative care? Well, it's specialized medical care for people with serious illness. Notice I didn't say terminal illness, and the care is provided by palliative care really focuses on relieving symptoms and stress related to the serious illness. The goal is to improve the quality of life. Palliative care is never provided by just one specialist. It's always a team, and it can be provided along with curative or disease-modifying treatment. Palliative care also focuses on really making sure that the patient and the family understand their illness and that their care aligns with what they want from life and what is medically possible. I wanted to put this graphic in this presentation because it shows when palliative care should be introduced to a patient and their family. Some years ago, patients were not getting palliative care until they were appropriate for hospice. The research has proven that the earlier the palliative care gets involved at the beginning of the illness alongside treatment, the better for the patient. These are the patients that we see in palliative care. And of course, we see terminal patients, both cancer and non-cancer patients. We also see many patients who are not terminally ill, but who have life-limiting conditions and who have multiple medical problems, especially the elderly in need of goals of care talks and support. We also get consulted on patients whose treatment has a curative intent, but also they may have a heavy symptom burden that palliative care specialists can help with. As I said earlier, palliative care is not just one provider. It is almost always a team. At the VA, we have 3 physicians, a nurse practitioner, a psychologist, and social workers. In our new patient clinic, when we see the patient and family together, there's usually at least 3 palliative care providers in the room with that patient and family so that we can make sure we're assessing all of their needs physically, emotionally, psychosocially, spiritually, all the realms. So, why should you as providers be concerned about providing palliative care to your patients? Besides the obvious, much all of the specialties have recognized the importance of integrating palliative care into their disease-specific population. And although most of the research of the integration of palliative care for disease-specific populations has been focused on patients diagnosed with cancer, you can find articles regarding the integration of palliative care from all of the specialties, American College of Cardiology, American Thoracic Society, American Academy of Neurology, and that list goes on. All of the specialties have really recognized getting palliative care involved early on in a diagnosis can really help overall with the patient and the family. And even more reason to integrate palliative care into cancer care is that multiple studies have shown that the integration of palliative care into the cancer care continuum, particularly early on in the course of care, results in improved patient outcomes across multiple measures, including survival, quality of life, symptom intensity, and end-of-life care. So the majority of time that we're being asked to have a goals of care conversation and helping patients and families with managing expectations is within the setting of delivering bad news. As we all know, the times that we have to deliver bad news to our patients is not the most comfortable. And my hope is by the end of this session, I will equip you with a strategy for making sure that these serious conversations are easier. And it takes practice. It's something you have to learn, just like doing any other procedure. So how do we help manage expectations of patients facing a serious illness? What exactly is bad news? Bad news is any information that significantly and adversely affects one's view of the future. It may pertain to a new diagnosis, a disease recurrence, a failure of treatment toxicity, or end-of-life issues. And bad news can certainly and most often threaten one's sense of hope. And what the patient may consider bad news, the provider may not, and vice versa. Why is giving bad news so difficult? Because in medical training, a cure is emphasized greater than psychosocial aspects of care. And most providers are very distressed when they're not able to give their patient hope. And providers may feel guilty about having to give bad news, and they want to withhold information. Most physicians are not trained to give bad news. Even today, when residents rotate with the palliative care team, it's still an elective. It's not a mandatory rotation. So there is lack of training. And most of the time, the first time we're trying out giving bad news, we're communicating this for the first time without ever having practiced this or having any education to prepare us to do this. So how do patients want to be told bad news? While though there's significant variability in the specifics, studies show that almost all patients want as much information about their illness as possible. Most patients want to be partners in the decision making about their care, and they want providers who listen to them and are empathetic when they get upset. In order for our patients to be partners in their care, they need to be compassionately told the truth about what is the best we can expect with their illness and treatment options, and what is the worst, and help them make a plan for both scenarios. If we only share with the patient the best case scenario, we are taking something away from them. And this brings us to the SPIKES protocol. The SPIKES protocol is the most common guideline that helps providers through difficult conversations. It was originally developed in the 1990s to use in oncology to disclose a cancer diagnosis. And over the years, it's also been shown to be effective in multiple healthcare settings. And this protocol helps to improve communication, increase provider confidence, and it encourages patient-centered care. So SPIKES protocol is displayed on this slide. It's a 6-step framework for breaking bad news in an effective and organized manner. So the first step is the setting. This is where all our planning comes into play. We've gotten the test results, we've made the diagnosis, and so now we have to plan for the conversation. This may be the first time we're seeing the patient. You want to try to know a little of who they are before meeting with them. If not, at least reviewing the chart again to remind yourself about the patient, so when you walk into the room, you're addressing the person, not just the diagnosis. Setting up also includes setting the room up, making sure that there are enough chairs for whoever will be with the patient. It's so important that when you know you're going to be delivering bad news, to have a plan before the meeting, to be in a setting that is private, to sit down and maintain eye contact while talking to the patient and the family. If you sit down, they'll feel like you've been there twice as long as you are. And standing gives them the impression that you are in a hurry, as well as can give a sense of superiority. Give your phone to someone else who can take your calls, or turn it off. Make sure they have someone with them, if at all possible, and if they want. In short, you want to arrange the physical setting to ensure uninterrupted privacy, sit close to the patient, and within reason accommodate patient preferences toward family members being present. You should block a longer time for these visits. I know this can be very difficult because of other appointments, but you will need longer than 15 or 20 minutes. And as much as possible, this should be done in person. So we were consulted recently on a patient. I'll call him Mr. Smith. He's a 77-year-old recently diagnosed with stage 4 non-small cell lung cancer with a malignant pleural effusion. In my review of his records prior to seeing him, I learned that Mr. Smith had not been seeing doctors routinely for a very long time. He lived alone, he had no transportation, and he hated coming to appointments or hospitals. He turned off his phone, and he was not answering his calls from the other providers. Now, I know this is certainly not feasible for most providers, but I decided after reviewing his records, we had to figure out a way to see him. So I made a home visit. This is the setting where he was most comfortable. And more on Mr. Smith as we go through the rest of the protocol. So perception. This is where you will use your ears more than your mouth, where you will listen intently to the patient and the family's understanding of what they think is going on. You will find out here what the patient knows or what they think they know, and you will be able to identify coping strategies such as denial, over-optimism, and avoidance. This is a good time to correct any misunderstanding or misconceptions. So how we do this is we ask open-ended questions such as, tell me what you have been told so far about your cancer diagnosis. And then be quiet and listen. So back to Mr. Smith. When I asked Mr. Smith what he understood about what the doctor had told him about his cancer diagnosis, he understood that basically he was diagnosed with cancer, but he was unaware of the staging and what the next steps were going to be. I learned as I listened to him that he was a loner much of his life, and that he did not really like going to see doctors, and up until this time had not really had any major medical problems and had been quite independent, but lately had only been able to walk within his apartment, and just a few weeks prior, he was still able to walk a couple of miles per day. So the next step is invitation. And this is essentially where we're finding out how much the patient wants to know. It's important to find out from the patient how much detailed information they want, because some patients will want to know all the little details, and some will just want to know the basics. Oftentimes, family members will want to know more than what the patient may want to know, and the only way for you, the provider, to know is to ask the patient. Make sure they are ready to hear what you have to say. You want to ask their permission, and particularly ask permission about sharing prognosis. Some patients will just want to know whether their cancer is incurable or not, but always ask permission before sharing prognosis. You can say, is it okay if I share with you what I medically understand about your cancer? In some cultures, the patient is not the one who initially receives the information, and they prefer a family member. So that's also something that we need to keep in mind. So back to Mr. Smith. I asked Mr. Smith how much he would like to know about his cancer, and Mr. Smith told me he wanted to know the big picture. He wasn't really interested in knowing all the details, but he wanted to know whether his cancer was incurable or not, and if treatment for his cancer was even worth pursuing. So then we move on to knowledge. This is the step where we actually share the bad news. And notice there are 3 steps before we actually break the bad news. I cannot emphasize enough how important it is to do the previous steps very well before breaking the bad news. And this is the most comfortable part of the meeting for us as medical providers. It's where we share from our toolbox of medical facts what we know about their illness. Be very careful the words you use when explaining things, like you want to say spreading instead of metastasize. Some examples of how you can start this is, I have some serious news to tell you, or unfortunately, Mr. Smith, your test result is not as we had hoped, or I'm afraid this news is not good. The most important piece about this step is to allow space for silence. As providers, we feel uncomfortable with silence, and we have this need to fill the void. When providing the medical facts, deliver the news clearly and in small chunks and in plain, simple language. Also, do not downplay the bad news or give the news too bluntly. Believe me, patients and families may often forget what you say, but they will never forget how you make them feel when you say it. It is critical to be compassionate with the delivery of bad news. We can never make bad news sound good. If we could, it would not be considered bad news. But the way you deliver it will have a huge impact. So back to Mr. Smith. I explained to him that unfortunately his cancer was not curable, and that any treatment would be palliative with the hope to extend his life and help him with some symptom relief. I further explained that there were further tests we would need to do before we could medically say what his treatment options would be and determine the risks and benefits from there. I explained the first step in finding out what the options would be were to meet with the oncologist, which previously he had not even been considering doing. More on Mr. Smith in a minute. So, empathy is the next step. This step is often skipped or we get over it very quickly. And I think this step is the hardest for providers because we tend to want to rush into the next step, which is where we're trying to figure out the next steps in the plan of care. The best thing to do after you deliver the news, again, is to be silent. I can't express that enough. Allow the patient and the family time to process what you've just told them. If you fly through this step, it is hard for the patient to move on to the next step of making decisions. We may feel bad, but we need to avoid premature reassurances until emotions are validated. We don't know how someone is going to respond. I have been in meetings with patients and their families where chairs were being thrown out of anger to being in complete silence where no one was saying a word. The most important thing is to anticipate some kind of emotional reaction and be prepared to explore their emotions without minimizing them. I often tell the patient and family that whatever their reaction is, it's okay. I give them permission to be feeling whatever they are feeling. It's important that no matter what the emotions are, to stay present with them. Some ways we can express empathy at this time is to provide active listening, maintaining eye contact, and leaning into the patient if it's culturally appropriate. You want to create an environment of intimacy and let the patient know that you care for them. Now, as a side note, of course, not all patients respond to empathy, particularly I find in our veteran population. There is a number of patients who just want the facts, and they're going to be very businesslike. You'll know who they are, trust me. Just follow their lead. Mr. Smith was one of these patients. He was very matter of fact about his diagnosis. He was understandably disappointed with the news, but he was also very practical. So the next step is strategy or summary. This is a time you'll share the next steps about the plan of care. What's going to happen now, and letting them know that they will not be alone in this. They will not be abandoned. Ask them to summarize what they understand and clarify any misunderstandings. We want them to know that after they get home or after you leave, if they have any questions, they can always contact you at the office. It's important here that you're not dictating the next steps, but you're strategizing with the patient based on their own personal values and beliefs, aligned with what you know is medically reasonable, and developing a plan together. I usually say something like, I know we've talked about a lot of things. Tell me what you heard. Tell me what you understand. When I reached this step with Mr. Smith and asked him to explain to me what we had discussed today, he was able to say that he had been diagnosed with an incurable cancer, but that did not mean that treatment would not be beneficial to the degree that he could have his life extended, as well as his symptoms better managed. But at some point, barring some other acute event, he would likely die as a result of this cancer. He agreed to see the oncologist for further discussion regarding treatment options, and thankfully for him, he had high expression of PD-L1 and was a good candidate for immunotherapy, which was right in line with what his goals of care were. So I'm the co-chair of the ethics committee at the VA, and I just wanted to include this Ethics 101 slide. We should always be mindful of the basic ethical principles. We need to remember that medical fact and our expert opinion should always be weighed against the principles of ethics. We should not be offering treatments and a menu of services just because they exist. We need to make sure that what we recommend is always medically what's in the best interest of the patient. Here I've highlighted some pitfalls that you want to avoid. The first one is I want to discuss just for a minute. You don't want to skip asking a patient who currently has decision-making capacity about their surrogate. Who would they want making decisions for them at a time they can't make their own decisions? I always like to tell the patient who their decision maker is going to be if they do not appoint someone. Usually, when I explain that to them, they're more amenable to naming someone. In the case of Mr. Smith, he was single, never married, he had no children. I did find out from him that he had one brother, and he was in agreement that he would want his brother to make his medical decisions for him when that time came. And I know you'll have another lecture that you listen to that goes more into healthcare power of attorney and advanced care planning. And I just wanted to take a few moments. I know you're going to learn some things as well about hospice in another lecture, but just to dispel some myths out there about hospice care. For time purposes, the answer to all these questions are yes. Patients who are on palliative chemo, who are full code on palliative radiation, etc., can also be eligible for hospice care, particularly at the VA where we do hospice concurrent care. There's only two criteria for hospice care. One is the patient is diagnosed with a terminal illness, and two, the patient, regardless of other treatment, has a life expectancy of less than 6 months. That is the only two criteria that is required for hospice services. So this is just a list of some resources if any of you are interested in learning more about palliative care from what you learned from our lecture series that you're listening to. One I forgot to list on here and I use daily is something called Fast Facts. It's a free app you can download to your phone. It's a wonderful tool that has evidence-based research and examples on symptom management and much more information about what I presented on today. Fast Facts. You can download that app to your phone. And then really just lastly, a little blurb about the PULSE forms. Again, you'll get a whole nother lecture regarding this, but 39 states now have PULSE documents, and these documents are physician orders for life-sustaining treatment that are portable from facility to facility in each of the respective states. It's indicated for those patients you feel have about a year life expectancy, and we complete many of these on elderly nursing home patients so that when they transfer back and forth from the hospital to the nursing home, there's a document that states these orders. And just wanted to let you guys know about this document so that you can incorporate it into your practice wherever you are when needed. These are just some references that I use for this presentation. And this is how you can contact me, Robin Rome, nurse practitioner with the VA Palliative Care Team, if you have any additional questions about what I presented today, or if you ever need any help with any of your patients. Thank you very much for listening in.